Okay. Ready?
I am.
Pleased to be here today with Derrick Lowery at Christian Northeast Hospital. He is a supportive and palliative care physician and an emergency physician at Christian Northeast. Longtime friend, a graduate of Washington University School of Medicine's emergency medicine program. And he's got some extra training that I want him to tell us about, as well as some of the initiatives going on at Christian Northeast. He's going to be joining us in November for the combined grand rounds with St. Louis University and WashU, called Senior Friendly Emergency Care, what doctors, nurses, hospital administrators, and ancillary providers need to know. Welcome, Derrick.
Thanks for having me, Chris.
So, my pleasure. After your EM residency here in St. Louis, you completed a palliative care fellowship at Emory. What made you want to take on this additional training?
One of the things that I found is, I graduated from Washington University Emergency Medicine in 2014. And as I started to get ready to go out into the real world and practice community medicine, I felt that I had this deficit in knowledge about how to take care of people who were facing life-limiting conditions, how to communicate better with them, and even for those patients for whom the goals were very clear, how do I get their symptoms managed? And I didn't feel that I had enough training to provide that level of care. So I wanted to kind of fill in that knowledge gap and go and get the fellowship training.
Okay, well, I commend you for that. You and I wrote a chapter together on end-of-life care for the cardiovascular patient, and you opened my eyes. You showed me a world that I had never thought about, really. We do it every day, right? We do it every day, but I guess we get distracted. I guess we've got other priorities and other interests, maybe, and maybe sometimes it gets a bit sad. It's a tougher part of or it doesn't have to be, but it can be a tougher, sadder part of the job. So I think we do lose the overall objective sometimes.
And the one thing that I always like to respond is there's an emotional theme that comes up when people hear what I do, and that's of sadness. And I always like to respond and say, I think there's actually something very rewarding and fulfilling about matching the medical interventions that you're doing with the goals that the patient has. One of the things that when, I went through emergency medicine training that was really beat into our heads was that the interventions that you tailor are to save lives at all costs. That's sort of the driving motto behind our thinking process and how we as emergency medicine doctors think. So we approach every patient that comes through the door looking for what is it that's going to kill this patient, or what is the immediate life threat, and how do I intervene, or how do I intercede. But the thing that really kind of opened my eyes was I had somebody share with me once. They said, everybody that comes through the doors of the emergency department is coming because they have a distress. But that distress is not always that they are at the end of life and want that reversed or intervened upon. And so when I started just very bluntly asking patients, help me understand how it was that you decided to come to the emergency department, it opened up my eyes to the fact that maybe it wasn't that they were asking for me to help them live longer, or what I like to call move the finish line of their life. But maybe they wanted me to help them cross that finish line with some dignity or comfort or whatever that may be. But I didn't have that skill set, and so that's why I kind of decided I needed to go and do a fellowship. And in terms of is that sad, I don't think it's sad at all. I think it's an honor and a privilege to care for people when they are at that final stage of their life. One of the things I always show the medical students when they come to my office is, I have kind of a box of thank you cards, heartfelt, beautiful cards from families for patients that I've cared for. And interestingly, they almost all are from my palliative patients. These are patients who did not survive. These are patients who invariably, most of them die. And yet those are the people who are the most grateful. It's not the people who are saved, whatever that definition is. And so I do find it very fulfilling and not sad in the least.
Well, maybe you have to bring that box of cards with you in November to show everybody the
Sure.
rewards of this work. I really hope after November a few more follow your path. As a member of the teams that created both the EM resident core competencies, what geriatric EM skill sets every EM resident is going to need to demonstrate, both on the written exam and clinically taking care of patients. And that was derived with the help of ASAP and AMA and the American Geriatric Society and EMRA, ABEM, many others, as well as as one of the people who put together the geriatric ED guidelines. We tried to incorporate palliative care principles into our recommendations. How well do you think that current EM residency training prepares residency grads to deliver palliative care in real-world, non-university ED settings?
Well,
or maybe
first of all, I think you
settings?
and your colleagues are to be commended in moving the needle and bringing this issue do to the national level and saying, this is an area that we have to improve. Our population is aging. Our patients that we are seeing are sicker. Our resources are only finite, and bringing to the front of this topic and saying, hey, we've got to change how we're training. We've got to have this experience. We've got to have these tools and these skills is tremendously important. And so you and your partners are to be commended for all of that work.
Thank you.
In terms of how it's being done, I think the first step has been recognition that this is historically a gap in how we are trained. When I did training just 2 years ago, I got 0 lectures on how to communicate. I did not get any tips or tools of how do you respond when someone comes in upset with the language of do everything. It's very common. It's extremely common. I'm sure that you've seen it this week in the ER. Someone comes in saying do everything. And the response is not a door has just closed in a conversation when that language is used. That's a door opening to complete and to go farther and to hear more. And the fact that we're only now starting to engage with residents and with nurses about how to respond, I think there's a lot of opportunity to get a lot of opportunity to improve. And I think it has to start with the educators, the teachers. You can't teach something that you yourself aren't comfortable with and you aren't familiar with. And historically, this has been a skill that we're supposed to just have. We're human beings. We don't talk to people, so we don't teach it. But it is a skill, just like putting in a central line and just like an intubation. We would never send an intern in to intubate somebody without supervision, and yet we send an intern to go talk to the family. Somehow it's okay to send an intern off to go and talk to a family member without giving them the tools of how. But we would never do that with a line. So learning
so much
that
more
it's
difficult
important.
too, right?
Right.
So much more difficult to put a line in. Yeah, and there's these hidden biases too. If you show up in November, Derrick will tell you now humorous, it wasn't so humorous at the time, story about one faculty member's hidden bias emailing about Derrick Lowery's ambitions. So there are hidden biases you need to overcome as well, both internally from the teacher and from the faculty as a whole. But be there in November, we'll tell you the story. So what do you see as the most significant challenges then for more widespread delivery of palliative care to an aging society in coming decades? Obviously, educating the educators is going to be one key step.
Right. I think educating the educators is the first step. The second thing that we have to do is a recognition, and that's kind of what we're doing now, a recognition that the one-size-fits-all model of adult emergency medicine doesn't apply to the geriatric population. And also I want to add, the geriatric population and the palliative population, although there certainly is a lot of overlap, there is not 100% overlap. And I certainly want to make sure that, that I suggest my area of specialty and my expertise is on the palliative side. That does not mean that every geriatric patient should have as their goal, or should be assumed to have as their goal, exclusive focus on comfort.
Right.
However, for a significant population of them and a significant number of them, the percentage of care or the amount of dedication to the care that they want on comfort is going to be higher likely than other patients. And so recognition of that is really important. And I think that's kind of what this forum that you're hosting is going to start bringing to the learners.
And as emergency physicians, like you said earlier, we're trained to intervene, to do something to save lives. And when what you got is a hammer, everything looks like a nail. And this is a different objective for us that we need to contemplate. It's important, most importantly for the patients and families, but also for society as a whole, so that we choose wisely when we're spending that healthcare dollar.
And aside from just the healthcare dollar in the big national picture, I think on the individual level, if we shift the focus and even rename the emergency department perhaps the distress room, this is where people come when they're struggling, when they're in distress. For the geriatric population in particular, who have medical complexities and have perhaps multiple subspecialties caring for them, they have not responded to the interventions to address that distress in an outpatient setting, and they've come to us. So this is not somebody for whom a Percocet and a discharge stack of papers is going to be sufficient. So, how do you manage someone in distress when they have not responded to what we are used to using for pain? Having the knowledge that there's another layer of support to be added. And that's why I, in my title, when you introduced me, the title that I have is supportive care, because there's another layer that we have to recognize exists in specialty for the care of people in distress. It exists, and we have to expand that.
So tell us a bit about the Christian Northeast Hospital palliative care innovations that you'll be presenting in November. What are you guys up to up there?
Sure. Well, we have a couple of exciting innovations here. Since I do have two hats in this hospital, both on the emergency side and the palliative side, I've been really working hard to build a bridge between the emergency aspect of care and the palliative side. The first thing that I've been doing is working with my colleagues and arming them with very specific language that they can use that I'll be sharing at the symposium, how to respond to certain things, how to elicit what the best care possible for each individual patient is, and then how to help implement that. Logistically, there are some things that we're putting in place here to help make that happen. The first thing is we have 4 dedicated comfort suites, and this is something that we've been very, very proud of. And these are 4 rooms in the hospital that are designed for patients who have as their goal exclusive focus on comfort. These are special rooms, so even the smallest details that we've put in place, for example, one of the things when we talk to patients that causes them to be uncomfortable in the hospital setting is being awakened frequently. So let's analyze that. Why are we being awakened? Because nurses have to do vital signs. Why do nurses have to do vital signs? Because we have policies in place mandating it. So there were a lot of small little steps and a lot of interdisciplinary team conversations that had to take place to get every member of the team together, nursing, dietary, social work, everybody together and figure out how can we make this a more home-like setting. For example, our comfort suites aren't off the main hallway of the hospital. They're at the corner, so they don't have to hear traffic walking by. Dietary. Patients hate hospital food. Actually, everybody hates hospital food. So how do we make it so that families can bring food in? We have to have somewhere for them to heat the food. We have to have a refrigerator for them to store the food. Patients get lonely. How do we have it so that families can sleep in the room with the patient? We have to have a pull-out bed for the family, and we have to have a loosening of visitation restrictions for these rules. So those are some of the plans that we put in place for our palliative comfort suites. The other initiative that we have going in place is a streamlining of disposition from the emergency department to the home with hospice setting. And one of the things that Dr. White, the Chief Medical Officer of BJC Hospice, and I have been working on, we're very proud of, I can now get a patient discharged from the emergency department home with a nurse and a bed and all their drugs faster than I can get a patient upstairs to my own hospital admitted. And that took some effort and some energy. But it's a model that's replicable in other facilities. And so I'd be really excited to kind of share what we're publishing here and let other people copy it.
That is marvelous. You've been out of fellowship 2 years, you said?
1. This is my first year out.
Jeez. Kudos to you. Wow, what energy and ideas. I look forward to hearing so much more. I had the opportunity to go to St. Joe's Emergency Department in New Jersey a couple of years back. They've got the second geriatric ED, really the first, because theirs is really primo. And they've got a palliative care section, 2 palliative care rooms. Very cool, and they've got peaceful music playing, and it's away from the nurse's station, so it's quiet.
Right.
Something for the family to sit and to sleep if they need to, like you described. They've got a big screen TV against one wall that shows wind blowing through the fields or a nice ocean hitting the coast. So very peaceful and a nice way to leave the world if that's the course that you're on. And so, yeah, we can do this. We can do this. Christian Northeast has done it. This is a citywide event that we're going to have, and it doesn't matter whether it's an SSM hospital, a BJC hospital, a Mercy hospital. I guess the administrators probably don't like that, but we need to work as a team because this is a team-based sport, and none of us can do it alone. And that goes more for just the hospital system, but the specialists as well. We've all got to work together from the pre-hospital setting to the ED to the inpatient or outpatient worlds. You've done that,
Right.
and you've brought these parties together. And I think that's the potential that this day in November has, is that we are bringing a very different group of people together, both from different hospital systems and different specialties. That's the strength of geriatrics, is that you really can work as a team. So anything that you in November would like to see presented or discussed in particular?
I think one of the things is I think we have to start from the very, very beginning. And I think it's great to have these large esoteric conversations about how to care for populations. And I think that's an important conversation to have. But I also think we have to make sure that we don't get bogged down in sort of mental gymnastics of grand ideals. And I think we have to arm people with very specifics of what they can do when they go to work the day after the symposium, and what they can do to care for the patients that they're inevitably going to see. So what I'm hoping to bring is language, specific language that can arm people, because there are two kind of groups of physicians. There's physicians who feel that they're very comfortable, and there's physicians who kind of shy away from this patient population altogether. And what I'd like to do is kind of shift everybody into that group that says, I'm comfortable having these conversations. This is a skill. I need to learn it. I can learn it. I can get better. So I want to arm people with some very specific language, specific responses to the situations that they will find themselves in.
Well, I think that if attendees walk in having watched the jerryem.com module and going through those cases, I think there'll be a big step forward into really grasping what you're talking about and taking some of these ideas and hitting the ground running on day one post-conference. Derrick, thank you so much for talking with us today. Really looking forward to November, and I think this is going to be a good day for the city of St. Louis.
Thank you.
Thanks, Derrick.